data products for research on health, aging, education, and labor force outcomes. Finally, we will hear from Rebecca Wong. Dr. Wong is the Sheridan Lorenz Distinguished Professor in Aging and Health at the University of Texas Medical Branch. She joined UTMB in 2008 to serve as director of the World Health Organization Pan American Health Organization Collaborating Center on Aging and Health. She is also vice chair of research at the UT School of Public and Population Health, co-director of the Claude Pepper Older American Independence Center, and director ad interim of the Seeley Center on Aging. Dr. Wong's research agenda focuses on the economic consequences of population aging, in particular in Mexico and among immigrant Hispanics in the US. Dr. Lee, we will start with you.
Thank you. Good afternoon. It is my great pleasure to participate in this dialogue, thinking together to put aging populations at the center stage of the global public health agenda. I'm a professor of economics at the University of Southern California, and I study global population aging and its implications for the society and individuals. The population age structure has changed radically. Next slide, please. Over the years, as you can see shown in the figures, the global life expectancy soared from only 34 years in 1913 to 72 years in 2022. And it is expected to continue on that long-term trajectory. Meanwhile, between 1970 and 2020, fertility dropped in every single country in the world. These shifts portend a closer set of health, social, and economic challenges in the coming decade. Addressing all these challenges will require meaningful changes in lifestyle behaviors, public and private investments, institutional and policy reforms, as well as technological innovations and adoption. The potential consequences of inaction are dramatic as well. A dwindling workforce training to support burgeoning number of retirees, a concomitant explosion of age-related morbidity and associated healthcare costs, and a declining quality of life among older people for lack of human, financial, and institutional resources. Next slide, please. Recognizing this critical importance of population aging, the United Nations General Assembly declared 2021 to 2030 as the decade of healthy aging. Here, the health is central to all our experiences of older age and the opportunities that aging brings. The aging of the population impacts our health systems, but also many other aspects of society, including labor and financial markets and demands for goods and services, such as education, housing, and long-term care. Next slide, please. The United Nations identified 4 action areas for the decade of healthy aging, which are first, combating the ageism. This calls for changing how we think and act toward age and aging. Second, age-friendly environment to facilitate the ability of older people to participate in and contribute to their communities and the society. And third, the delivering integrated care, and that is responsive to the needs of the individuals. And this person-centered care approach has been highlighted in recent dialogue. And finally, the providing access to long-term care for older people who need it. And this attention to long-term care has been even more rising in recent few years. Next slide, please. And such United Nations resolution mandated WHO to track progress toward these decade-long goals. This mandate recognizes that what is measured drives the action. So action needs to be informed by the evidence and aligned with older persons' expectations and the priorities that are negotiated with various stakeholders and resourced by decision makers. And this setting up baseline status report and then following up how we are achieving these goals through evidence-based information driven by various data sources. Next slide, please. And when we started working on tracking the goals, people have recognized the lack of data. And this lack of data on health aging or lack of data on older population increases the invisibility of older people. So spearheaded by the United States National Institute on Aging, there are increasing number of longitudinal population aging data available around the world. Currently, there are 47 countries around the world collecting longitudinal data on aging population. This rich data on health and health behavior, together with socioeconomic information, offers the opportunity to study healthy aging and the factors that promote and hinder healthy aging around the world. Next slide, please. While these data provide important evidence basis for understanding health of the aging population and its social determinants, there are still over 100 countries lacking such data. Filling this void, there are currently several new data collection initiatives. For example, National Institute of Health's initiatives on brain aging in Africa, WHO's initiative partnership with the Trichfield and collecting additional data on health aging, and recent effort by the Age and Development Banks to track aging population in low and middle income Asian countries. Next slide, please. This healthy aging is the process of developing and maintaining functional ability that enables well-being in older age. The focus on the healthy aging is indeed a paradigm shift from disease-free status to optimizing functional ability. There has been rising attention to functional ability and how we can optimize those functional abilities by providing proper environment as well as facilitating and building up the intrinsic capacities. Next slide, please. The paradigm shift has been also observed moving from single disease to recognizing health and biological changes and vulnerability, as well as moving from single occupational exposure to interrelating working life exposomes. Further conceptualizing social environment, thinking about not only the interpersonal relationships and social isolations, but also getting into structural social environment captured in ageism, sexism, and other aspects of macro social environment are seriously considered. The importance of physical environment for aging population has been also well recognized, and there is an emerging literature on natural and built environment, as well as paying attention to the air and quality of water and contamination associated with both air and water. The policy influences key determinants of health, either by directly influencing individual determinants, including policies that affect access to healthy diets, tobacco consumption, physical exercise, injury prevention, or social participation. Policies also influence communities and national determinants, such as policies on education, transportation, employment and retirement, urban design, pollution, and healthcare. Next slide, please. Healthy aging will not be possible without a healthy planet. Human activities and influence have warmed the atmosphere, the ocean, and the land, increased the frequency, duration, and magnitude of many weather and climate extremes, such as heat waves, precipitation, droughts, and tropical cyclones. There are increasing and concerted calls for emergency actions to limit global temperature rises, halt the destruction of nature, and restore biodiversity. Air pollution and extreme weather events and food insecurity are already harming health. Without the rapid, large reductions in emission, climate change will become the leading global risk factors for extreme mortality and threat to human physical and mental health and well-being, including for older people. Healthy aging and healthy longevity for most people will not be possible without the healthy planet. Next slide, please. People have been neglected in studies of climate change, and climate change and rapid population aging are occurring together, and their combined effect on the health and well-being of older people have to be better understood and addressed urgently. It is important to also note that older people can be agents of change in actions for the climate. Older people are also disproportionately affected by climate change because of their greater physiological susceptibility, pre-existing health conditions, disability, and social vulnerability, particularly when they live alone or in poor urban areas and less capable of responding. Older people must be protected from climate-related threats and calling for multi-sectorial policies and programs in cities and communities. This is an opportune time to increase the visibility of older people and to advocate for a healthy planet. Next slide, please. The next 10 years will be critical for the agenda of both climate change and healthy aging. Thank you. Thank you for the opportunity.
Thank you so much, Dr. Lee. That was really interesting. We move now to Dr. Torres.
Thank you so much for having me. I'm really delighted to be part of this panel with such esteemed and close colleagues. So I'm going to switch gears, although many of the themes that I talk about are very relevant to what Dr. Lee just presented, and talk about gaps in equitable social and long-term care policies to support older adults and their family members. Due to the constraints of time, I'll mostly be talking about the US context, although many of these themes are relevant when we think about global aging as well. So just to set the stage, the vast majority, over 90% of older adults in the US prefer to age in place in their homes and communities. But many require supports with health conditions, activities of daily living, and economic needs. So just for context, the vast majority of adults 65 and older are living with at least one chronic health condition, so diabetes, heart disease, etc. And over 60% experience what's known as multimorbidity, so having two or more chronic health conditions, which increases the risk of adverse outcomes and economic costs as well. Among these chronic health conditions, an estimated 10% of older adults live with dementia in the US, and another 22% live with mild cognitive impairment. As a result of these health conditions and other factors, a large number of older adults require assistance with personal care needs or mobility limitations. So these can include personal care needs such as bathing or eating, as well as routine activities such as shopping or managing medications. There is substantial variation in the prevalence of needing help with self-care needs or mobility limitations, including by health status, but also the prevalence of needing support with activities of daily living is higher for women, for older adults of color, for lower income older adults, and can be, exacerbated in the context of chronic health conditions. So for example, one national study estimated that 78% of individuals who had dementia needed or received assistance with self-care or mobility limitations. And then finally, millions of older adults struggle to make ends meet economically. So about 10% of older adults are estimated to live below the federal poverty line, but many more experience economic insecurity, which I'll talk about a little bit more. Unfortunately, the landscape of kind of social and long-term care policies to support older adults and their family members in addressing these health and economic needs leave much to be desired. There's a great deal of confusion about how long-term care is paid for in the US, but it is largely covered under Medicaid, which is available only to low-income adults, so those who meet income and assets eligibility criteria. Otherwise, costs must be covered out of pocket and/or by long-term care insurance, which is held by the minority of older adults in the US. Medicaid has been rebalancing to support home and community-based services in line with the preference of older adults to age in place in their homes and communities, so focusing less on covering nursing home care and more on the kinds of supports that people need to remain in home, such as in-home support with meals, transportation, and those self-care needs that I mentioned at the beginning. But the generosity and kind of family supportive nature of these home and community-based services vary widely by states because they're governed under state Medicaid policies. So for example, many states have long waiting lists to be able to even get access to these critical home and community-based services, to get access to in-home support with personal and routine care. And there's lots of variation in the extent to which family members, so including spouses, may be able to be eligible as paid caregivers under these home and community-based services policies. In the US, we have no federal paid family leave policy, unlike many of our peer high-income countries, which would provide opportunities for family members, so adult children or spouses, to take paid leave and have enhanced job security when they need to support older family members who are experiencing acute or chronic health conditions that require intensive care. Social Security retirement benefits fall very short of covering true expenses of daily life, driving kind of the high prevalence of economic insecurity we saw in the first slide. So this point has been made very clearly by researchers at the University of Massachusetts, Boston, who published the Elder Index and calculate that on average, Social Security retirement benefits fall about $1,000 short of covering true expenses for older adults per month. Although there's substantial variation geographically by health status and housing status, as you can imagine, the cost of living and the cost of housing varies greatly. So this gap can be much larger in many contexts. And then eligibility for safety net programs, so food and housing assistance for older adults, is based on the federal poverty level, which in 2023 is $14,580 for a single person annually. So the same folks who run the Elder Index project at University of Massachusetts calculate that this is less than half of what a single older adult who is renting their home would need to meet their basic needs based on national averages alone, let alone imagine covering the cost of long-term care. So these are just some of the examples.
Dr. Torres, just so you know, there's a little bit of static coming through. If you don't mind moving your papers away from the microphone, it may be helpful.
Thanks for that. Sorry about that. These are just some examples of the gaps in social and long-term care that are present for older adults and their family members. And the implicit or explicit assumption of many of these long-term care and social policies in the US as well as globally is that family members are going to fill these gaps. So they, at least in some part, if not entirely, family members are going to cover the personal care needs, the economic needs, and so forth that are left to be filled based on what's not covered by these social and long-term care policies. But this assumption may be unrealistic given demographic changes, economic realities, and so forth. So in the US, 27% of adults 65 and older live alone. There's a slightly higher prevalence of living alone among women and with increased age. And both in the US and globally, the size of family networks are shrinking. And projected to shrink even further over the course of the 21st century. So this is recent work by demographers and the proceedings of the National Academy of Sciences projecting for each country in the world what the kind of size of family networks are expected to be, and they're expected to be shrinking rapidly across the board. But there's also expected to be changes, and there are changes happening in the structure of family networks, which may also affect the ability of family members to provide care, which we might be able to talk about in the Q&A. Even when family members are present, they may face barriers to addressing care needs due to distance, economic challenges, constraints of policies related to paid leave and caregiving, and their own health conditions. So this is work by from a recent study that I led with my colleagues using nationally representative data from the US, and we estimated that in any given year, 2.3 million adults 50 years and older were co-residing with a spouse or partner who was living with cognitive impairment or dementia. So dementia, including its most common subtype, Alzheimer's disease, requires very extensive and intensive care, particularly in its latter stages. While the majority of co-residing spouses do manage to provide care to their partners with dementia, a non-trivial percentage face their own health challenges, which may make providing such intensive care difficult. For example, we estimated that about a third of women who are 80 years and older who are living with a spouse or partner with cognitive impairment or dementia themselves had difficulties with personal care needs, such as getting out of bed, bathing, eating, etc., which again may make it difficult to provide all of the intensive care left by the gaps in our existing policies. So the result of these gaps is that, and their high variation across states, is that the prevalence of unmet needs and adverse consequences related to these unmet care needs is high. So these are the results of a national study of Medicare beneficiaries that found that, for example, among those who needed support with managing medications, 20% reported making medication errors as the result of not receiving sufficient care with this routine activity of daily living. Large percentages also went without groceries or personal items or without hot food. And a large percentage reported having to stay inside as the result of not getting assistance with their mobility limitations. A much smaller percentage reported having to stay in bed, while a smaller percentage, this is a very severe adverse consequence related to unmet care needs. And my final point is that the outcomes and experiences of older adults as they intersect with the social, economic, and policy landscape are inequitable. So let's take one example. So here's the estimated prevalence of economic insecurity among single adults in the US. A portion of these who are experiencing economic insecurity are living below the federal poverty line. But there are still many more who are having trouble making ends meet because of that mismatch between the actual cost of living and what's provided under Social Security retirement benefits and other benefits. The prevalence of economic insecurity is much higher among older adults of color as compared to their white counterparts. So reaching above 70% for Black older adults who are single, and nearly as high for Latina older adults who are single. So these inequitable outcomes in late life emerge across a backdrop of life course accumulated structural, social, economic, and related inequities that have occurred across the life course. That have made it such that older adults of color and women are more likely to experience poor health, to be Medicaid beneficiaries, to be relying solely on Social Security retirement benefits and so forth, so therefore more acutely impacted by the gaps in policies that I described. So social and long-term care policies in the US and globally need to be grounded in the preference of older adults to age in place, but also the actual cost of living for older adults beyond the federal poverty limit. To expansively consider the family unit, thinking about paid family leave and other economic policies that we might think about as pertaining to younger middle-aged adults, but may be critically important for supporting the care needs of older adults. But also acknowledge the demographic realities of changing kin network size and availability. And finally, prioritize equity in policy setting and outcomes. And I very much look forward to the Q&A. Thank you.
Thank you so much, Dr. Torres. That was really interesting. We are turning now to Dr. Warren. Thank you.
Bear with me as I struggle with my technology. I seem, hold on. There we go. You're seeing words. I'm going to assume so, unless I hear otherwise.
I saw some words up. I saw a white screen up and now it's gone. So if you'd like more time, we can. There's a white screen up now.
I see.
And I see words now.
Okay. Sorry about that. So thank you for this opportunity to talk today. I've learned a lot already from the first two presentations, and I look forward to the discussion at the end. By way of introduction, I am Rob Warren. I use he, him pronouns, and I'm a sociologist by training, a demographer by job. I run a population center. They tell me that I'm an education researcher as well. Again, I'm struggling to advance screens. Well, it appears to be working. I'm a population health scientist. As Dean Galea mentioned earlier, I run a population health training program. I consider myself sort of a wannabe epidemiologist, having published in the top journals, but having no training in epidemiology. And what that leaves me, again, baffled by what's going on with my screen. Perhaps I can ask Tara to advance the screen, or whoever has the power.
Dr. Warren, if you can just cue when to advance the screen, we'll be able to advance it for you.
Okay.
I think we may have lost him. I don't see him on the screen. So, Erica, do you want me to, should we flip the order or should we wait a bit?
But we can move to Dr. Wong, and then we can go back to Dr. Warren.
So Dr. Wong, you are up.
Thank you, and thank you for the invitation. Erica is going to show my slides. There they are. My highlights today are on aging in low and middle income countries with a focus on Mexico. Next. The key points that I would like to make will be made with illustrations from Mexico. The first one is the speed of aging that we referred about how this happened fast. And so I will illustrate that it's much faster in low middle income countries than what the previous high income countries experienced. And of course, we understand the implications of that. The second point is that these fast gains were also present in socio-demographic conditions of older adults, but they were not accompanied by gains in health among survivors. And the third point is that the well-being of older adults in Mexico continues to persistently be linked to the United States. Next, please. The first point is about the speed, as I said. This is called an accelerated aging in low and middle income countries. And this is evident, this is a very classic statistic, first by the proportion of the population 65 years and older in Mexico was 6% in 2010, projected to be 15% in 2036. So in this very short period of 26 years, they go from 6 to 15% of their population be 65 and older. This is compared to other countries that did it before, but the United States did it in 69 years, achieved this 15% in 2013, and France took 115 years and achieved this 15% in 1980. So the low middle income countries are achieving these levels of aging with low socioeconomic levels, and they're poorly prepared then to meet the challenges to provide healthcare, as we've been hearing. And in particular, for example, in many countries right now in Latin America, there's no universal health insurance or social security system, and less than 50% of those populations 65 and over in Mexico are covered by pensions. The speed was, of course, due to the gains and how fast we heard how fast mortality and fertility dropped in these countries, and the timing, the ones that are aging right now, are the ones that dropped their mortality and their fertility around that same second half of the 20th century. Next, please. The second point that I said I was going to make is that there were gains in socio-demographic conditions that also were very rapid. So for example, if we compare the cohorts that are age 50 to 59, right before they enter age 60 in Mexico, just within 17 years. So for example, the percentage of that had less than 5 years of education went from 61% in the year 2001 to 25% in 2018. So in those 17 years, that generation that entered before they entered old age, the level of education rose significantly. And the mean number of children, as we said, the fertility dropped, then it was manifested. Then if you are at age 50 to 59, in 2001, you had 5 children, whereas in 2018, in those age 50 to 59, had only 3 children. There's a significant gains then in education and the number of children they had. But these gains were not parallel by gains in health behaviors. Again, among those entering before they enter old age at age 50 to 59, the percent of men who ever smoked was 63% in 2001 and stayed about the same, just 59% in 2018. So the gain was not present. And similarly for women, the percent ever smoked was about 22% in 2001 and in 2018. So the more recent cohorts, those who enter age 50 to 59 in 2018, show Expanding disability rates. These are very concerning patterns, but among these younger, more recent cohorts, we see worse health. Obviously, some is because of survival, but not all of them can be explained by lower mortality rates. Next. And this graph only shows, the exhibit shows that the rising trend of obesity that accompanied deaths, as we were saying, not the parallel gains. So this is the population age 53 and older across those 20 years, females in pink, males in blue, and we see a very clear tendency for a rise in obesity. And this rise in obesity was parallel with a rise in diabetes and cardiovascular diseases and other chronic conditions. And so this trend is very similar in many Latin American countries today. Next one, please. And the third point that I wanted to point out is that the aging in Mexico continues to be closely linked to the US. Of course, Mexico is closely linked to the US, period, but aging is in particularly linked as well. Despite the rise and drop, the ebb and flow of migration from Mexico to the US over the last 2 decades, the proportion of males that are age 60 and older in Mexico who are former migrants to the US was about 16% in 2001 and continues to be about 15% in 2018. There's no change in that pattern. And also that means that those who are former workers in the US and are now living in Mexico, they have less protection from institutional support for old age in Mexico, for example, by pensions. They conducted most of their working lives in informal labor markets. Even when they came back from Mexico from the US to go back to Mexico, they continue to work in the informal labor market. Also, if we look at how many of those people who are older, age 60 and older, men or women, who have at least one child living in the US, we see about 29% of those who are 60 and over have at least one in 2001, and continues to be about 24% in 2018, like I said, despite all the changes, drops and rises in migration. Next, please. And to finalize, I just wanted to point out that I think the lessons that we can learn now from these countries that are aging, from the low middle income countries that are aging now, can be useful for other LMICs aging in the future. These lessons are critical for public health, as we have been understanding and listening, and because other low middle income countries are following or may follow the same very similar paths. So for example, we're learning, or we need to learn more about how they recover from shocks, how they respond to policy changes, what are the long-term effects of the life course they experience. The childhood conditions turn out to be very important. And so these childhood conditions of disadvantage, how do they manifest in old age? How can we break that chain between childhood conditions and old age health and well-being? What are the physical and cognitive consequences of occupational and environmental exposures? Again, in many LMIC, low middle income countries, these occupational and environmental hazards are pretty high. And so we need to understand how we can, again, break that chain. What are the benefits of the way they use their time, of the social interactions that we know it's pretty lively and active in many low middle income countries, the living arrangements that are very different in low middle income countries than in rich countries or high income countries, and that the patterns of family caregiving are much different and more intense in low middle income countries. And so what are the consequences of that, both as benefits and consequences for the caregivers? And finally, we have, as Jim Cook remarked on how many countries we have these kinds of studies now, we're learning a lot from cross-national differences and similarities that we see in associations. So that for us, for example, in the study with Mexico, about 20% of the research that's being produced within Mexican data involves cross-national comparisons right now. And so lastly, the importance of data collection on aging in LMICs, I think is recognized. But we are then producing a lot of evidence on associations. But looking back, I think that more work is needed to understand the mechanisms of these relationships. Thank you very much, and I look forward to questions.
Thank you, Dr. Wong. That's really a lot of food for thought. And now, Dr. Warren, we return to you.
Okay, thank you, and sorry for the difficulties earlier. I was saying earlier that I am a sociologist and demographer, education researcher, population health scholar, but in recent years, I've become sort of a wannabe epidemiologist and an amateur cognitive aging scholar. And so the comments that I offer today are sort of as a tourist to these fields. I have learned a great many things from my colleagues and from various projects, but I am fundamentally a social scientist. I was asked, nonetheless, to reflect on these two questions that I think guide the webinar. I'm primarily going to focus on the second, how we can better promote the health of aging populations nationally and globally from a research perspective. As someone who has spent a lot of time hanging out with folks in public health on a variety of projects. And I basically want to say 6 things. First, and all of these points will have come up in the previous presentations, but I'm going to elaborate on several of them. First, later life conditions have early life origins. If we're interested in promoting the health of older populations, we need to think about early life. This is very much like the streetlight effect, the old adage that, or it's an old joke, I guess, that somebody was found looking under a streetlight and asked if they lost their keys there. The cartoon says wallet, and the person says, no, I left them somewhere else, but there's more light under the streetlight. I very often think that aging researchers are somewhat guilty of something similar, considering later life health by looking only at later life. In fact, there's a great deal of evidence that any number of early life conditions, exposures, circumstances shape later life health. For example, this is from a paper that I published with 2 students looking at the long-term cognitive consequences of exposure to lead in childhood. The red line are children who were exposed to lead. The horizontal axis is age, and the vertical axis is a standardized global cognitive score. At age 60, people who were exposed to lead in childhood had about a quarter of a standard deviation lower global cognitive scores. The point is that if we focus only on late life solutions and late life conditions to late life health problems, we miss a big part of the story. Lead, of course, is not the only early life thing that matters. A quick list might include education, not just how much, but also the quality of education that people receive, exposure to adverse childhood exposures, where people live, geography matters, environmental exposures like lead, exposures to infectious diseases, and more. All of these things shape later life health. If we want to promote the health and well-being of older people, we need to think about changing circumstances for children so that future older people will be better off. A second point that I want to make is that no later life health problems are solely biological. And of course, this is related to the first point. Any health, whether it's a cognitive health problem or a cardiovascular health problem or a functional limitation is purely biological. And I'll give you a couple of examples. I've been doing work in recent years on dementia. There is a collective wisdom that an important predictor of who experiences Alzheimer's disease is the biology of plaques and tangles around the neurons or in the neurons of the brain. While this may be true, the fact of the matter is that the vast majority, or at least a large majority of people who have these physical symptoms or these physical attributes, nonetheless, don't experience Alzheimer's disease. They live their lives, often very late into life, experiencing cognitive normality. What shapes who actually experiences dementia and who doesn't, given the same or similar physical conditions, biological conditions? That's a social question. That's a question of resilience and who can who has enough cognitive reserve to avoid those symptoms. So it's even Alzheimer's disease, which we increasingly know a lot about the biology of, is also a social condition. Another example, there's growing work now on the microbiome, both the gut and the oral microbiome, and its relationship to any number of diseases. And it would be easy to consider this purely a biological process, but the number one predictor of the composition and diversity of the gut microbiome are things like diet and where you live. The number one, or one of the number one predictors of the composition and diversity of the oral microbiome is access to dental care. These are things that are fundamentally social. These are not purely biological processes. So when we think about improving or enhancing or supporting the health and well-being of older people, again, we need to combine biological and social or economic perspectives. The next point I want to make is that from a research point of view, no later life health problem can be solved or even really meaningfully addressed by any single discipline. This sort of follows from my assertion earlier that health conditions are always fundamentally both biological and social or economic. But what this means is a challenge to the public health research establishment, also to the social science research establishment, to do more meaningfully interdisciplinary research. If you are trying to address a health problem or a health concern among older people anywhere in the world, your research team, to really make innovative and impactful advances, should meaningfully include not a token representation of people from many disciplines, but really a fundamentally interdisciplinary team. And this often requires discomfort. It requires researchers to listen and learn new languages, new ways of doing research. But that is the price to pay, I think, for really meaningfully supporting the health of older people. The next point I want to make is about racism. Folks who study, from any discipline, folks who study later life health are very attentive to racial disparities in any number of health or cognitive conditions or even mortality, but they often fail to name racism as the fundamental determinant of those issues. The same could be said of sexism or other ascribed statuses, but I'm going to focus primarily on racism. For example, here are age-adjusted stroke mortality rates in the United States at 2 points in time, and it's probably very familiar to people who do research in the US that those rates are much higher among non-Hispanic Black people than among any other group. There is, and this, what I'm about to say is true for almost every health and cognitive condition, no fundamental biological basis for expecting higher stroke rates among people racialized as Black. That is the end result of a long series of complicated interacting forces that somewhere or multiple somewheres include racism. Otherwise, there is no basis for anticipating these racial differences. And I think it's important to keep that perspective in mind when we're talking about inequities by race in later life health or cognition. Next, I want to highlight the role of growing economic inequality. If you buy anything that I've said to this point, you would accept that social and economic conditions across the life course shape the health and well-being of older people. If that is true, then we should be alarmed by growing economic inequality, particularly in the United States. This is less the case in other parts of the world, although it is the case in many parts of the world. In the United States, the top 1% of income earners have gone from earning about 10% of all the income to now earning about 20% of all the income since 1980. The bottom half of the United States, with respect to share of income earned, has gone from 20% to about 12%. This is just one indicator of rising economic inequality. This means not good things for large shares of the growing population of older Americans. Comparable things are occurring in other parts of the world. Finally, I want to highlight something that's come up in various ways in the previous presenters' talks, and that is that the health and well-being of aging populations is fundamentally a political issue. We spend a lot of time talking about the nuts and bolts of particular policies that shape the health and well-being of older people and their caregivers. We need to remember that there is great power in the politics around aging. One obvious example in the United States was the implementation of the Social Security system, which drove the poverty rate of older people from being the highest among all age groups in the United States in the 1960s and before to being the lowest. It's now children who are particularly at risk of poverty. That's fundamentally a political issue. This is one example of how politics can directly shape the health and well-being of older people. So I hope I've spoken at least to the second of these questions, and I will wrap up so that we can hear from the audience.
Thank you so much, Dr. Warren. Really compelling. And I think we've got a lot of stuff to talk about here. And I'm going to ask all our panelists to join us now for this discussion part of the event. So if you could please turn on your cameras. I think you all have your cameras on and your microphones. And I do have some questions of my own. So I'm going to start out with that before we turn to audience questions. But in the meantime, a reminder that the audience can submit questions using the Q&A feature at the bottom of your screen. And we will turn to those shortly. I wanted to start again with Dr. Lee. I was really struck by what you said about climate change, among many of the other points you brought up, as being one of the really crucial factors in the next 10 years for the health and well-being of older people. And this is, you know, people talk about this as a young person's issue, and it's, you know, the young people who are out there on the front lines. But could you talk about why this is so important for older people, and what would be some recommendations for you, like the maybe 2 or 3 of the most important shifts that you would recommend to help older people also come to terms with climate change?
Yes, thank you. I think climate change, as you reiterated, is one of the important challenges that nobody can escape from it. And what makes elderly or older generation more vulnerable is that many times the limited functional ability, they cannot escape from it. And especially we have been struck by various climate events in many parts of the world, not only low and middle income countries, but also high income countries. So let's think about an example of recent flood in California. There has been a landslide and flooding that hits the Americans at older age, and being able to get away from the flood and the landslide, you really need to have a nimble functional abilities. And that declining frailty makes it a lot more vulnerable. And that also is the case in recent earthquakes in Japan. So even in older population in high-income countries that is experiencing such challenges. Another important aspect of it is, as Rob has mentioned it is also quite tied with the economic conditions. So many of the extreme heat or extreme cold weather has been increased the mortality of aging populations, because many of the people, in places in London or places in rural India, people exposed to such a climate, they just don't have enough heat or enough resources to buy the heat or enough resources to cool down the hot temperature. So those kind of issues make the older population a lot more vulnerable, and also the population that is placed in low economic status. And I think what is important to remember is, as I noted earlier, the aging population can be an agent to make these changes, because it's an important voice to voice out, climate change will influence their health conditions and their ability to deal with it. And being able to advocate for healthier planet would be one of the most critical issues for aging population can address.
Thank you. And before we leave this topic of climate change, I want to open it up to all of you because several of you mentioned, changes that can be made on, the local, but also the federal level, and in some cases, possibly even global level. Is there any policy that any of you can think of that would be potentially most effective for people to be focusing on any of these levels in terms of climate change in the older population? I can pick someone if you.
Well, for us, of course, we talk about preparedness and the need to prepare the older population in the United States. Nursing homes is a particularly vulnerable population with this climate change. And so thinking about what are the targets of populations and identifying what are the most vulnerable in these climate change events would be priority one, right? While somebody else is taking care of how the climate change is ameliorated, it's like minimize the consequences to this population would be great.
I think another way to think about it would be like service provision, right? We have programs like Meals on Wheels and providing, what is most needed to the older population. We can think of it similar ways when there is an emergency situations. We need to pay attention to reach out to aging population and take care of their need in such emergency situations.
I'll chime in. I don't know that this is kind of the highest priority, but I think one priority that I know a number of people are advocating for is that a lot of our long-term care and social policies that are aimed at benefiting older adults have income eligibility requirements as well as assets eligibility requirements, meaning that older single person may only be able to acquire, $2,000 or $3,000 total worth of assets before they no longer meet eligibility to get that critical ongoing long-term care or housing or food benefits. But if you are only able to amass that amount of assets, then you don't have the ability to manage a kind of a catastrophic event, a climate event in which you have to evacuate, in which you have to buy a generator in order to, continue to power the medical devices that you may have that require electricity. And so kind of adapting and responding to these climatic events that may require economic resources is extremely hard for people when they're also trying to, have to maintain these assets, these very, very low assets in order to meet eligibility for these social programs.
That makes sense. Dr. Torres, I want to stay with you for a minute. You had mentioned several paradigms where women and people of color were more affected than the general population. And I'm wondering if there are any specific adjustments or approaches that you have seen be effective in terms of addressing that disparity and trying to, equalize things a little bit.
Yeah, I know, I think there are lots of different kind of varying experiments in terms of Medicare and kind of the provision of in-home care. I think, in many states allow for this consumer-directed care model where older adults can kind of hire and fire their own in-home care providers. And so in some cases, that can really allow the flexibility for older adults to hire even their own family members, their adult children as in-home care providers, or, to select care providers who may be culturally concordant, linguistically concordant, and so forth. So that may allow a lot of flexibility and kind of being able to have care providers that align with the needs of older adults. But there are also challenges with the consumer-directed care model. For example, older adults who are experiencing cognitive impairment or dementia may have particular challenges kind of with the consumer-directed model. I'll also just mention, in historically immigrants to the U.S. have not been eligible, for expanded full scope Medicaid, and which covers a lot of the long-term care that I was noting. California has recently expanded their full scope Medicaid coverage for adults 50 and older to be delivered regardless of immigration or citizenship status. So that would be inclusive of many older adults of color who have immigrated to the US.
Thank you. Okay, does anybody else want to add to that question before I move on? Well, let me let you guys jump in. I don't want to jump in. Okay, because what you were just saying sort of led me back to what Dr. Wong was discussing in terms of, people in Mexico who have had this very sort of fluid relationship with the United States over multiple generations. And I was really struck by what you said, Dr. Wong, with, people who've come to the US and worked here and have not accrued any, Social Security kind of in either country. And then some of them also have children who are here. And I'm wondering if you can elaborate a little bit more on that relationship, because it seems to me, I mean, you said that this, some of these factors are present in a lot of other low and middle income countries, but it feels to me that there's a particularly strong relationship between Mexico and the US in that sense. And how, well, there's a kind of two-pronged question. Are the changes in our immigration policy in recent years, do you see that changing this relationship and these numbers? And then B, I'm not quite clear on how the role of the child being in the US, like, is that protective or not? Like, are people sending money back and helping, or is the fact that their kids aren't there actually hurting them?
Okay, good points. Yes, indeed, the relationship between Mexico and the U.S. is special, right? Very, very long, and it's very close, and it's a very long history of interactions. And I wanted to call attention to it because we cannot talk about aging in the U.S. Of the, say, underrepresented groups of Mexicans and Mexican Americans without thinking about what they have on the other side, Mexico, and vice versa. We cannot talk about older Mexicans in Mexico without thinking about that many of them have an interaction with the U.S. And so, and again, there are, for example, the first point that you raised about having a long-term work career, say, in the United States, and then you go back to Mexico, and in old age, you are in Mexico unprotected. And for many years, we've been talking about what they're called totalization agreements, which is that the years of work in the U.S. count when you go back to Mexico, and vice versa. If your children in the U.S. decides that you should move with them to the U.S., the years of service in Mexico would count for old age support in Mexico. So anyway, it's so that it's a total number of years that should be counted, and that's a major policy change. That it's a policy reform that is being mentioned for many years, and for a while it was almost implemented, but it hasn't been. But that's a very, straightforward, if we can implement it, way of saying, you should be counting your contribution in both countries. From the perspective of the second one that you said, the disadvantages of in having a child in the U.S., it could be an advantage and it could be a disadvantage, right? Obviously, having a child in the U.S. is stressful to the older adult in Mexico. You don't know if your child is okay, especially if they are undocumented in the U.S. and so on. It's stressful. It's also stressful to have them far away in another place that many times you cannot go visit and so on, different language. But it can also be very advantageous because if you don't have old age support, your children can, in the form of remittances, send money and support to the older parents. So that's the kind of codependence that we were saying for old age. It's an undeniable codependence between the two countries. And so it could be pro, and that some of the research shows that could be advantageous, but also disadvantageous, in particular for mental health. But advantageous in economic well-being and also in ability to provide for healthcare in Mexico because you get remittances from the U.S.
Thank you.
Thank you.
Just in the interest of time, I'm going to turn to some of these great questions that we're getting in from the Q&A. So they're not in any particular order, but there's a question here that I'd like to start with Dr. Warren. The question is, social isolation and loneliness among older adults is a growing concern related to health and well-being. Can you speak to this challenge and how this fits into the public health agenda for change?
Yeah, that's an important question. I knew nothing about the research on loneliness until the last few years, and I've really been powerfully impressed with its relationship to any number of mental health and cognitive conditions, and also the degree to which it is stratified by social position. Loneliness feels like an individual problem, but it's in fact a public health issue that I think rivals many others. A great deal of the research, of course, came out of COVID, where we were all somewhat lonely, but I think it just highlights a larger problem that's been with us for a long time.
Absolutely. Does anyone else have anything to add on loneliness? I'm gonna power through some of these questions then, because I'm worried we won't get to them all. There's a question here I'm going to direct to Dr. Torres from Anthony King. I'm going to massacre your name, Cangelosi. I work with the New York State Department of Health. We are focusing on a master plan on aging developed by the entire state, in that we are developing tools to increase data utilization and provide future policy recommendations among many refinements to long-term health governance. In what ways would you suggest that departments of health, especially ones in large states, can transition from being transactional reporting-based organizations to forward-thinking, proactive, research-oriented organizations capable of addressing the issues mentioned by all of you today?
Wow, that is a big question. I'm not sure that I have all of the answers. But I think one conversation that's being had in California, and this is being pushed by an organization called Justice for Aging, which is a policy and advocacy group, is the focus not just on kind of quantifying expenditures on home and community-based services and in-home supportive care, which I'm guessing would be a big part of this master plan on aging, as it is in California, but really understanding the outcomes and understanding the extent to which they're equitable. So really being able to quantify and survey the extent to which needs are being unmet and the consequences of those needs. So we actually have very little, even national level data on the kinds of unmet needs and the consequences of those unmet needs that I showed. We do have population level data in California, and it's kind of worth, I think, investing in understanding the extent to which needs continue to go unmet, both by those who are utilizing Medicaid-funded long-term services and supports, but also the general older adult population, rather than just tracking expenditures and services provided.
Thank you. Anyone else want to jump in? All right. Next question I am going to direct to Dr. Lee. Again, it's about climate change. It's a popular topic. What advice do you have for local public health and other related groups to prepare and be more responsive to climate change and older adults as more adults live longer and are aging in place? I know we talked about it sort of on a macro level, but for local public health and other related groups, what specific advice or recommendations would you have, Dr. Lee?
I think the first priority action that we have to all consider is how we can dramatically reduce the emission of the coals. So especially from the local authority, I think it's very important to think hard about how we can reduce the consumption of the gasoline from the cars in everyday activities. We have seen many successful examples in various European countries by providing more bicycles and more public transportations to lower emissions, and those are very important considerations for us to consider. And also in terms of reducing the helping the planet health, we have to pay attention to various waste management protocols and water protocols. There are so many things that local government can take an action upon. And the pricing as an economist is a very important consideration of how we price our water, how we price our gasoline. And it would be, the consumption can be much more based upon the quantity of its consumption instead of placing a flat fee on, the amount of, regardless of amount of the garbages or amount of water people use. If we can penalize the quantity of water that people use or quantity of emission they produce, I think that can have a dramatic impact on reduction in those kind of harmful productions.
Is there a model anywhere for a place that has done this well that we could look at?
I think that's a very good example. I can put out couple of local examples because those are done much at the municipality level. I have not seen any successful examples at the country level, but I have seen more examples at the small municipality level, achieving much greater success in conserving water and reducing the core emissions.
Thank you. Now here's another question on countries. So I'm going to turn to Dr. Wong. The question is, not many countries, and I imagine they mean low and middle income countries perhaps, not many countries have social security benefits or grants for the elderly. Is there data on aging, poverty, or health challenges in countries that don't have financial assistance? And I suppose if so, where might we find that?
Yes, it's probably, the UN data that documents the ability of older adults to have access to pensions and also then the poverty level. But it's very closely related because in old age, right, the sources of income diminish. You're not longer in working age. And so the source of income has to be either a pension or family help, or if you accumulated property, you can have rental income, right, and so on. And so tends to be, in particular in low and middle income countries, it's family income. And so it's help from the family that it comes from when there is no pension program.
And is there a
So
place
if
that
I
we can
may-
see data on this? I'm sorry, Dr. Lee, I will just wanted to follow up to ask if there is a place that has actually put together data on these countries. And Dr. Lee, maybe you are answering it too. So both of you.
Yes, there are various sources of data on the elderly poverty. Like easiest way to get that for low and middle income country would be like World Bank data sources, as well as OECD, some of the more middle income country data you can see. The point that I like to add on to that is even some of the middle income countries that has introduced this social security pension type of programs, many of them are actually funded system. So for example, a country like South Korea is very now high income. They introduced the social security system for their elderly population, but still the elderly poverty rate is very high because this is a funded system that requires contribution during their working years. So often the current elderly, when they were young and working, such program didn't exist. So the future elderly will be benefited from this program, but current elderly do not. So I think those are very important considerations to think about whether pension system is funded system or it is not funded system. And the other point that I like to make is, as an Asian, one of the greatest myths a lot of people believe is in Asia, children will take care of their parents. But that is really not true, especially in these newer generations. So many of this, the previous family care system is collapsing. The elderly are really in the very difficult place. Without the societal pension system is not in place, the children move on to their own lives without taking care of their parents. So there is a lot to think about, and we need to be cared about.
That is a
In
really
particular,
good-
as you were saying, because as we saw, the fertility dropped very fast. So having fewer children means that you have fewer possible caregivers in old age.
Thank you. There's a question directed specifically to Dr. Torres. I'm going to read it out. Thank you for your enlightening presentation. How do you believe addressing staff shortages among formal caregivers in long-term care facilities will contribute to alleviating the stress and challenges faced by informal caregivers of the elderly? Additionally, could you share your predictions for the future of long-term care facilities in the US?
So this is pretty far outside of my wheelhouse in terms of kind of the healthcare workforce. I do know that many nursing homes are facing severe staffing shortages that have accelerated under the COVID-19 pandemic. And are closing, are at low capacity, and therefore not able to provide adequate care to their residents. I mean, I think that this is just going to contribute to the overwhelming preference that older adults already had to remain in place and age in place, and put additional pressure and requirements on state and local governments to provide care in homes. So it is actually much cheaper to provide care in homes, but it's not adequately provided. And if you're not covered under Medicaid or long-term care, even under those programs, there is not adequate kind of meeting of all of the needs that older adults have. But if you are in that gap of people who don't have long-term care insurance and aren't eligible for Medicaid, then you need to cover everything out of pocket. And so, I mean, I think I'm not exactly sure, what the future of long-term care facilities is going to look like. I'm sure in the US they will continue to be there. They're much not even really part of the conversation in most global settings. Just want to redirect back to the kind of overwhelming preference that older adults have to remain aging in place in their communities, but struggle to do so given the patchwork of long-term care that's provided to them. And I think I'm imagine that the staffing shortages in long-term care facilities is only going to accelerate and accentuate that preference.
So I would follow up, and this is for all of you, is there a viable path politically for, funding people who are informal caregivers or family caregivers, or, kind of helping people age in place in that way? Like, do you, see, kind of given our current political environment, do you see any way that could reasonably happen?
Well, I'll just add, so under the policies, again, are variable at the state level. So under Medicaid, if you're eligible for Medicaid and you are eligible for receiving care in your home, in-home supportive services, there are provisions for family members to be paid as care providers. Now, there are some limitations. So some states say it can be your adult child, but not your spouse, even though your spouse is, if you're co-residing, likely going to be providing that care. And often the payment is very low. First of all, it varies by state and county, even within state. And then it doesn't cover all the hours that people are actually providing that care. So it often provides, payment for a very small percentage of that care. So just to lay the groundwork that there is already kind of, at least under Medicaid, opportunities for family members to be paid. The eligibility requirements are variable, but in terms of other models beyond the setting of Medicaid, I'd love to hear what others think.
Yeah, I was thinking about what a caregiver program that can be expanded is an older adult worker who's still working, right, and needs to take time off because the spouse needs care. That is not particularly a benefit right now that is generalized, right? It's not available. And so that could be a possibility. There are many spouses, like you said, that are the primary caregivers or the first ones, but that need perhaps some support when they're still working in family leave in a way.
Yeah, actually, thank you for bringing that up, Rebecca, because I yeah, well, I'll just reemphasize the point about paid family leave. So we have no federal paid family leave policy in the United States. We have some states that have passed paid family leave policies. They're often thought of as policies that are mostly for providing for parental care in the context of like a newborn baby. And actually the uptake of paid family leave among older adults or their potential caregivers is pretty low. Now, they don't provide, sufficient weeks of paid family leave for addressing a chronic health condition such as Alzheimer's and dementia, which is going to extend for many years, but may provide some relief. And that's, for spouses and so forth to manage kind of the acute needs and maintain job security and pay. And we are shamefully lacking in a federal paid family leave policy.
Another policy that is very closely tied is immigration policy, because the long-term care workers are often hired in that industry. So we will have definitely impact on wage rates of the long-term care workers.
That is an excellent point. I'm going to address the next question to Dr. Warren. Kind of relates back to what you were talking about with social conditions. And the question is, any thoughts on models for older populations who are chronically homeless?
I think this relates to what Dr. Lee was saying about issues related to water. There are many models. Every municipality seems to be different with respect to how it polices the homeless versus supports the homeless versus provides service. These are very, in the US, very local state, but often local policies. And then I know that there's tremendous heterogeneity across countries. I think this is an area where some models work better than others. So I think there are models. This is outside of my wheelhouse, but this is an area where I think, while it may be unfortunate in some ways that localities are left to think about how to support homeless older people, it actually provides a bit of a laboratory for seeing what works and what doesn't work and what works better. So I think there is some hope.
I can add that, so in California, under, again, the same Medicaid in-home supportive services program, before 2020, people who did not have what was previously considered a home, so people who are unhoused, did not qualify for in-home supportive services on the basis of not having what met the formal definition and the policy definition of a home. And that has been changed as of 2020, such that to expand the definition of a home to be inclusive of providing care to people who are unhoused. I'm not sure about kind of the implementation in other states, but that's the kind of expansive policy I think that we need.
Thank you. Dean Galea, do we have time for one more question or should we wrap up?
One more question.
Okay. One more question from the listeners is related to disaster planning. And again, since this is climate change related, I'm going to start with Dr. Lee. The question is, any thoughts on the impact of disaster planning? And I'll add, kind of, again, are there places where you see this going well or any promising areas either globally or locally?
Thank you. And I feel a little bit, I did an injustice to the climate change topic, as I'm not quite an expert on that area. However, I do think it's a very important topic for all of us to think about. And I think one example that I can provide as doing a great job in terms of preparation is like a country like Japan, how they prepare for earthquake, and the cities and the local communities are well equipped with these unexpected disasters and being able to deal with it, not only taking care of emergency actions, but also the follow-up on those disastrous areas. So I think there is a lot of lessons to be learned as a people in the US. Thank you.
Okay, well, I know we're almost out of time, so I'll wrap up the discussion. And I want to thank everybody for joining us today and our esteemed panelists. It was really an honor to moderate this discussion. Thank you.
Well, I'll just jump in to echo the thanks. I want to thank Tara for masterful moderation, Drs. Wong, Warren, Torres, and Lee for really interesting comments. And I want to thank the audience. I thought there were really is a flood of really interesting questions. And I think you can see in a conversation like this how engaging this issue is for many of us who are interested in health of populations. And I feel about this conversation the way I feel about good conversations, which is to raise more questions than perhaps answered. And that is perhaps appropriate for the stage we are in thinking about this. So thank you to everybody who's on as part of this conversation, either on the stage or in the audience, for what you do for moving these ideas forward. Everybody have a good afternoon, evening, or good day. Take good care.
Thank you.